Hey there. Welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Good morning, Megan.
Good morning, Roxy.
We are coming at you today with a fun topic. But before we dive into that, Megan, tell me something good about the life of Megan.
Yeah. So just so everybody knows, Roxy and I were talking, and I think we're going to try to start doing this, like, tell me something good when we start our conversations, either with our personal or professional life or whatever, and with our guests, because I think that, well, we think that, it's helpful. And also, believe us, we will share you too when there's something not good. Tell us something not good. It's also, excuse me, if I cough through this, I've been a bit sick and allergies. So, yay, Kansas. My something good. So this happened about a couple weeks ago, but it was one of those moments that just like burned into my brain and just made me smile so big. But I've been seeing this 4-year-old in the clinic for constipation, and shout out to his mom, because, when you're treating littles, the home exercise program and all the stuff falls in mom's lap because they're little, so they're not going to do it. And so we've been working together, and I see him kind of spread out. But anyway, he came in and she was telling me this is probably going to be our last visit. And because he's been doing so well, and she's telling me about it, and he just busts out really loud. He's like, I had the biggest poop. And I was just so proud of him. And I gave him high fives, and we just like celebrated, because when I first met this little guy, he was so scared to go poop, and it was so painful. And I remember I gave him bubbles the first visit to work on blowing to help with the pelvic floor. And I said, these are going to help you poop. And he looked at him and said, I don't want those bubbles. I don't want those, because he didn't want to poop. So to go from that to him coming in and like, couldn't wait to tell me about his big poop, and that he asked to go and he says he needs to go. It was just amazing. So anyway, that's my something good. And I love it because, the little guys, it's challenging because it's not your typical treatment approach. So yeah. What about you, Roxy? Tell me something good.
Oh, goodness. Well, mine is not very clinical. I can make it clinical. It's like almost like stump the preacher, like stump the pelvic floor therapist. How can we bring this back around? But this is a whole nother sidebar, but my dad got some goats.
Oh boy.
Like yes. We're talking big time. Like there's like 100 goats. There's tons of goats. Okay.
Oh, Roxy, I got to come out there.
Okay. Yeah, you do. They're quite fascinating. So we went, he just got them. And they're just like, he's going to put them in his pasture and they're going to clear. They're very functional. They're purposeful. Yes. They're not pets.
Yes.
Thing. But so I took the girls out. I said, let's go check out Gramps' goats. And we had a phenomenal Saturday afternoon. We just walked around the goat pen, and they were very observant about their goat poop. It's very much like,
I love it.
It would be very constipated on a human scale because it's pellets, right? Coming out. And, but anyway, we did that, and then we went out, and we just were at the pond then, and they were throwing rocks in the water. And I just was disconnected from time and didn't care what time it was, and we had no agenda, and it was just good to slow down and just almost be a kid again, of just like, man, I don't have to be anywhere. We don't have to be in a hurry. We don't have to be done at any time. We're just rolling. So anyway, that was my something good. We were coming off a spring break, so it was just a good weekend too of just spending time together.
Awesome.
Yeah.
So good. I love that stuff. You're outside in the sun. Grounding.
Yeah, it was refreshing.
And goats just make you laugh. So
yeah, I don't know that these are
have you seen those like baby goat videos, and they like jump and kick their legs, and so funny.
Yeah, we're about to probably have a whole bunch of those. So I'll probably
Well,
have another something good goat story if
funny
you're interested.
about the goats because last year we we couldn't figure out where my husband was getting poison ivy from. I don't know if you remember me talking about this, Roxy, but he kept getting poison ivy. And so we like searching our backyard for poison ivy. We were like, it's not back here. Like we cannot find it. And then I had a patient and she was like, well, what about out here at the clinic? And I'm like, well, I mean, he hadn't been there. It had been like a week or so ahead where he had trimmed the bushes. And she was like, well, it can not show up for like a week. She's like, when I leave, I'll walk out here and see if I see any poison ivy. Literally, she walked out. And I mean, those of you that have been at our clinic, it's like one side door. There's not a lot of like, then there's like a field on the back side of it, but there's a little bit of landscaping. But down at the end, thankfully, not where people are like coming through the door, down at the end, it was all over. Poison ivy all over. She's like, Megan, it's right out here. So, of course, I had to like ask the person who owns the building to take care of the poison ivy because my husband couldn't and I didn't want to and then get it on, oils and touch him because we found out he's like very allergic. But my solution was I wanted to get goats and just like pin them in this area and have them eat the poison ivy. So I'm anticipating the poison ivy is going to come back this spring. So I'm going to have to see if you could bring some goats on.
We'll rent a goat out. Oh, maybe we should start a little business. Goat
That'd be
rentals.
great. Yes. Cool. Well,
Anyway,
we
well,
are gonna,
enough of that. Yeah.
yeah, let's get going.
Okay. We're going to talk about today a big part of our practice that has big question marks around it as well. And that is the internal assessment portion of treatment. And this, we notice that a lot of patients come in with like along a whole spectrum of opinions about this topic. Some people are like, yeah, that's why I'm here. Like, tell me, like, this is something I don't know about myself. I want to know. Let's do it. And some people have zero clue that that's going to be a part of it because they've either been recommended by a doctor to come see us or they've read about, the benefits of pelvic health, but don't know that part of it could mean that we assess the pelvic floor thoroughly and accurately. So they have no idea. And then there's been times, and I feel like we could both share lots of stories of just people who have avoided coming or are scared to come because they don't want that, or they're afraid of what that is, or they're unsure or uncertain. And so we want to just really talk all things internal pelvic floor assessment today and try and create a really accurate picture for anybody who's listening, who's curious about this, in a way that just informs and doesn't scare or doesn't push, whatever that
Yeah.
is. And so that's our topic for the day.
Yeah. And I think, Roxy, what you said about it holds people back is definitely a lot that we come across in that, yeah, either they're, for whatever reason, kind of like embarrassed or we hear a lot like, I'm sorry that you have to do this. And goodness, like that's such a big statement, because this is what we do. Like I tell people, it's basically like if you went and saw a specialist that sees shoulders all day, this is what we do. And we don't think twice about it. I've fallen, before where I've gone to my GYN appointment and I'll think like, oh, shoot, I didn't shave or something like that. And then I stop myself. I'm like, oh, yeah, no, she doesn't even care. We're looking at this of like, how can we help? Like there's nothing odd about it to us other than the fact that we know it's very vulnerable and we have to move at a pace that we pick up on from the patient and what you guys as patients want and consent to. So I think as we move forward in this, we just want to caveat with saying, validating everybody that we recognize that this is hard for a lot of people because there are lots of things that can go into this is like, if there's been past trauma, sexual abuse, anything like that. And also know that you do not have to do an internal assessment ever. We are just here in this episode to talk about the value of an internal assessment and how it kind of plays out. Roxy and I treat very similar. So we're going to talk through like the space, the light, like all of that. And hopefully just give a little bit of of maybe like after you listen to this, like, oh, okay. And it doesn't sound so scary. Um, but yes, we recognize the intensity that this can give somebody as far as some anxiety behind it. And listen, I mean, I remember my PF1 course, I pelvic floor course 1, and I was going to have to, perform a pelvic exam on somebody, and they were going to have to do that to me. And I think I was more nervous to have it done to me than I was to perform one on someone. So we get it. Finding yourself a good pelvic floor therapist that you vibe with, if you will, that you can trust. Make sure you trust the person. They're able to hold space for you and whatever is going on that day with you. It might be that maybe that day your body is saying absolutely no, I do not want to do internal. We've got plenty of other things that we can work on those days. And if you're seeing somebody that's just not the case, you might need to probably have that conversation with them, but just making sure that you feel safe. So, all right. Anything else on that, Roxy?
I think you said it all. I think just knowing, I would just affirm all of that I think a takeaway from that would be consent. Like it's your choice, your treatment. We make a lot of recommendations. It's just like a surgeon that would make a recommendation for surgery. If you don't want the surgery though, then you can absolutely walk away from that. And I would just say as a consent, maybe a consent caveat for any of that. I think this statement or this idea goes across all healthcare industry of we are here to recommend from where we stand all the choices. And you, though, are the person and you are ultimately in control of that. And so I 100% want that in my room, but I also a lot of times try and advocate for people when they go to their specialist or they go to their primary or they go to wherever they're terrified about what's going to happen. What if they say this? I'm like, that's their recommendation. And you have the power to say yes to that or ask more questions about that. It's your body, it's your health, it's your journey. So anyway, that would be, so takeaway one of just like consent and choice is yours. And that trumps absolutely everything. And then the second part of that is I like, Megan, how you just said like, oh, if you're not feeling it that day, just because you say no one day doesn't mean it's no the whole time. And so sometimes people will say, oh, I'm not quite ready for that today. And that's absolutely okay. And sometimes too, people are like, I don't think so. And then maybe 3 or 4 visits down the road, they're seeing the value, they're getting benefits. And then they're like, you know what, let's do that. I think that is really appropriate now. And I see where, that could be helpful. So it just is a very fluid and a very optional. It's really what the patient is most comfortable with on that day. And we could know the best treatments and the best techniques that will actually be more harmful for the patient if they are actually not consenting to it or they just consent because they think that's what we want. Very much it needs to be something that the patient says, yes, I want this because I want to get better. And I think this is the way to do that. And y'all know your body better than we do and what your emotions are screaming inside of you better than we do. And so that's.
Yeah. So the tag to that would be it's ongoing consent. And even if you say, yes, I want to do this and we're in the middle of it and you change your mind, you can stop at any time. So moving forward, as we're speaking, keep that in mind that we're constantly consenting. Okay, here we go. So let's talk about, so internal could mean a couple different things. It could be an internal vaginal exam or it could be an internal rectal exam. And a lot of times when people hear rectal exam, they're like, whoa, what are we talking about there? And we'll talk about that more. But as you can imagine, obviously, if we have a male patient coming in, that if they need to have a pelvic floor assessment, if they need an internal assessment, that's the route we're going to go. And for females, we have 2 different options. But here's the thing. Often there's some really valuable information that we can get from doing a internal rectal exam, just because of the orientation of the muscles, and especially if you have tailbone pain and stuff like that. So there are 2 different assessments, but we're going to kind of walk through more vaginal exam to start with. Roxy, why don't you set the stage?
Sure. So I know if you want to go back on like pelvic floor 101, we kind of talked through the exam on an earlier episode, so you can check that out for sure. But really we're going to focus kind of on this internal portion of that so that you kind of know what to expect. And so really the first thing you should know is that we're going to talk you through it first. We're going to introduce with a model what your pelvic floor is. And so you should be very aware of like, okay, this is the area we're looking at and this is why. And so we should have kind of not a spiel, but just there's some really basic education that's going to set the stage for this. And there's a visual. We will show you visibly where we're going to be at, what that's going to look like, what opening we're going to go through. And basically, we're going to walk you through the sequence of what to expect. First of all, so that you have kind of an idea in your head of what this is going to look like.
Yep. And so that right away, you can tell once we kind of do that, most of the time people are like, oh, okay. Because when you go to your regular GYN pelvic exam, their purpose of doing the pelvic exam is a bit different than why we're doing our exam. Can spit that out. So we are going to be going through and assessing each muscle where their purpose is, they're going to go up, they're trying to feel your ovaries. They're just making sure like a more of a general check where ours is more specific. We are going to go through and show you that on the model. And then it's like, oh, there is a reason behind this. A lot of times people just don't even realize that there's muscles there behind the tissue. Like, we have skin and all that. They don't even realize that there's muscles. And so once we make that connection, a lot of times it doesn't become so unknown. It's like, oh, okay. So I know, Roxy, probably you're the same way, but we don't use stirrups. We're not using a speculum, although there are ways that pelvic floor therapists might use like half of a speculum if they're doing some different like assessment of prolapse and different things. There's some new techniques out there, but generally speaking, for especially that initial pelvic floor exam, we're not going to be using anything like that. Now, if we need to be assessing externally, if we're going to look closely at skin and that sort of thing, we might leave the lights up a bit so we can see that. But I know in our clinic, we turn the lights down, we make the room comfortable. There's nothing medical feeling about it. We have sheets on the table. We're not using any paper gowns, anything like that. And we try to make it as comfortable as possible so you're not staring up at bright lights. And we're very much assessing the entire time when we're doing any of this. We're watching for different eye contact changes, breath pattern changes, body tension, that sort of thing. And even though as patients, you might not realize, we might be talking, having conversation with you, but we're also very much on top of what it is that we're doing. And we know exactly what we're doing and why we're doing it. So yeah, we're going to make sure that the room is comfortable for you. And then we will start with an external assessment. And with that, again, we're asking for consent. Are you ready? And you walk through what we're going to do. And so we're going to do some what we call palpation, where we're going to press externally through some different areas around the vulva, down towards the rectum into the glute area. I'm going to kind of try to not use like specific anatomical terms just because I know our audience here. And you're going to let us know if anything is tender or sensitive. Does that reproduce pain that you're experiencing? Sometimes we'll press in an area, and I'm not kidding you, someone will say, oh my gosh, that shot up across my abdomen. And so that's kind of the stuff that we want to know. And then from there, that's when we'll stop and make sure, check in, you're good, probably change our gloves and move forward with the internal assessment. So, well, let me back up here too. When we're doing that external assessment, we're pressing, we're getting a lot of the superficial muscles. And so those are the little muscles that run through like bulbocavernosus, like muscles that are very superficial, closer to the surface, if you will. Okay, so as we're listening to this too, I think that it's important for us to talk about how there's 3 different layers in the pelvic floor. And we are trained to know which muscles are in each layer. And so as we're going through your pelvic floor, we're not, we know where we're at, and we will probably ask questions through that. And also we pick up on, some people we meet don't really care about the names of the muscles. Other people do. So we are going to meet each person where they're at and what they want to know. But we have the different layers, and I don't necessarily know that we need to go through each and every one of those muscles for this episode. But The deeper layers of the pelvic floor are going to be the ones that are closer back by your tailbone, which is often where we find a lot of tension if someone's dealing with tailbone pain and that sort of thing. We might find that when we're pressing on some of the muscles more anteriorly, that we trigger urgency or feeling like somebody needs to pee, or, that's it. That's the feeling I get when I think I have a UTI type of thing. So it's pretty interesting and cool the way that the pelvic floor reveals itself as we are assessing it. And while we are working through those layers, that's another way for us to be able to kind of get an idea of root cause as to one more little piece of the puzzle of figuring out why you might be having the symptoms that you're having. So Roxy, why don't, without me going into each one of the muscles, but we know that there's the 3 different layers. And so why don't you kind of walk us through that internal piece?
So during the external portion, if we're visually assessing and we're like poking, so we're going to have you uncovered a little more and like have that area just exposed as much as necessary. But once we we insert, basically we'll have a gloved hand, we'll use lube, and we'll insert one finger just about a knuckle deep there, and then go ahead and cover you back up. So then you're not just going to be exposed this whole time. And so then because at that point, we're just going off of feel and what you report and what we feel. And so at that first layer, it's only about a knuckle deep. And so we're going to palpate through, just like if you have problems with your shoulder or your knee and someone kind of pokes around on it and pushes on different areas. This is the same thing. We are palpating and pressing on the muscles to see if they're tender, to see if there's a lot of tightness there, to feel for any asymmetries in the tissue there. And so we're going to work through. And so depending on what side we start on, we do one side and then the other too. And so we're just going to stay on one side of the pelvis as we work through each of the 3 layers. And so, and through this whole time, we're maintaining eye contact. We're talking through before we move, like, okay, now I'm going to go, I'm going to move over a little deeper. Here I go. Or you're going to feel my hand follow that muscle here. Here we go. We're going to be talking through that all for you, watching your body language, and listening for your report. We're asking, how does that feel? Is it better here or here? Different things like that so that we can better gauge what we're feeling compared to what you're feeling. And so your feedback is really valuable to us, because just to see, I feel in my head, I'm saying, I feel this. What do they feel? And it's really kind of a team effort then to really go through each of those layers. And so what that then looks like is, as we go deeper, we'll walk you through, okay, I'm going to go a little deeper now, and you're going to feel my pressure here. And then I'm going to follow this back, or you might feel pressure back a little bit, And so anyway, we're going to walk you through until we get to that deeper layer. And we are systematically going through each muscle. We're not just going to go in there and press around and feel. Like, we are thinking through, okay, now I want to feel this muscle. I'm going to move to that muscle. We're going to communicate that generically to you. You aren't going to hear the inner workings of our brain, but we are going through name by name each muscle and visualizing that as we palpate it, and knowing exactly which muscle we're on so that we can start to connect dots of why your symptoms are happening and what's contributing to those, and then how we're going to treat those muscles. And so once we go through one side, then we're going to, remove our hand, cover you back up, switch gloves, go to the other side of the table, and we're going to do the exact same thing on the other side. A lot of times, if there's asymmetrical symptoms, I'll start on the less painful or irritable side so that your body knows what to expect. Then when we go to the other side and whatnot, that's just kind of what to expect there is we're going to be on one side and then we're going to be on the other side. And it sounds a lot longer than it really is.
Mm-hmm.
But just so you know, like we do this every day. And so we've got it down to a system. We've got it down to an art of, we know, we can go through that pretty quick. It might look complex to you on the model, and it is complex, but we have a system that we're going through and kind of a checklist of every muscle that we want to touch and we want to feel and we want to assess. And then we do that right and left. And is there anything you want to add to just the assessment part of that, Megan?
I was just gonna kind of add to that of Before when we do our history and our questions that we're asking and walking through, especially in the complex patients, something that happens over time as you've been doing this for a while and that this is all you do, you start to really be able to notice patterns and pick up on things that maybe we didn't quite do earlier in our careers. But often, especially if maybe somebody's very flared up, I've taken enough history before we do that internal assessment where I'm going to know where I'm probably going to be tolerated and where I'm not going to be tolerated when I'm working internally in the pelvic floor. And sometimes it's a matter of in that first visit, I need to be able to assess just a couple of things and we need to be done because the body itself is not going to handle it. And again, we know, and there's a rhyme and a reason about what we're doing. And you may not know that because you're not, again, in our brains and can't hear our thoughts. But just knowing that there is a system of why we're doing it the way we're doing it. And we might have you do things like historical way of assessing, is like also this whole how fast can you contract and what's your strength like and all that kind of stuff. And honestly, doesn't necessarily give us the best information. So we might have you do a contract, relax, and walk you through some down training and breath work so we can feel what's happening in your pelvic floor after we do some muscle assessment. But, some individuals are like, what's my strength like? Like, I want a number. I want to know my strength, and that's just so honestly, there's so many things that go into that. That I think we've talked before about how strength can be very misleading. In our last episode about pelvic floor tension, which you haven't listened to that, you might go back and listen to it, that, a tight muscle is going to not coordinate and function properly. And so, we take it for what it's worth in that first assessment. We just really want to get a baseline for where we're at. Yeah, it's just so powerful. And so many women, after they've had an assessment, are like, wow, that was the most informative appointment I've ever had in my entire life. And like, goodness sakes, it's so empowering when they walk out. But yeah, I don't think I have anything else to add, Roxy, to the assessment piece of it, other than we're going to listen to what your body is telling us, and we know when to stop, we know when to pull back. And again, just if you're listening to this and you're nervous about an internal exam, also again, just knowing that we can also be done at any time, which is cool.
So let's also, while we're on that, a couple things to then consider is that if we do, that was a vaginal, that was us walking you through basically a vaginal assessment. If we choose, to do a rectal assessment, the flow is very similar. It is different anatomy though. And so our thought process is going to be different for that. But for the most part, it's the same. The feeling's a little different because it's also has a different purpose in life. And so you can kind of imagine what something in your vaginal canal, if you're a female, a vaginal canal would feel like. The rectal, I usually give people the warning, is it feels like you're going to, like you're pooping your pants kind of. Like it just feels like poop because
Yes.
all that canal, the only purpose it has as far as sensation goes is to let you know that you have poop coming down and that you need to make your way to the bathroom here pretty quick. And so anyway, that's like the biggest, that's usually what I warn people. And I never, it never ceases to amaze me that it is that whenever like we
Yeah.
have to do stuff in lab or work on practice
Yep.
on each other, if that's TMI, pardon me, but it definitely does. I'm always like, did I just poop? And
I
it's like,
know.
oh, I know better. But anyway, that is basically what the rectal assessment is essentially the same as the vaginal. It's just different anatomy, a little bit different sensation. But it's the same. We're sequentially going through. We're going to find your tailbone. We're going to find the muscles. We're going to go through the anatomy and try to make sense and connect dots and better understand why your symptoms are happening.
Well, and I just have to say, just a little shout out to the good old having rectal work done is I know it sounds so out there and uncomfortable, but if you are somebody who has dealt with tailbone pain for a long period of time, I totally respect and understand. You're like, nope, I want to try all the other things before I do that. And I'd probably be the same way. But we have some really great outcomes by being able to release those muscles right at their attachment. We are literally right there on the tailbone. We can mobilize your tailbone, move your tailbone. And so I would just like, just a little moment of encouragement. If this is somebody who's listening to this that has had tailbone pain for a long time and hasn't really known where to go or what to do, find yourself a pelvic floor therapist, specifically one that can treat rectally. And again, if you are somebody you're absolutely not going to do that, there are other ways to work around that. However, that is just one piece as a therapist that can just be so great. So, okay, moving on to treatment. So the assessment is one thing, and then treatment is another thing. So on that first pelvic floor assessment, which will be done, at any point that you want it done, but maybe first, second visit, again, we're just like capturing information. But treatment, there are things that Roxy and I both, it's so great when we're working together because, there are things after you've been doing this for a little while, you pick up on techniques or ways to try something that you were not taught in a course. And I will say for us in our training, a lot of times when you make it through some of those initial courses, it really is about assessment and not as much as in treatment. So when we treat, there are different ways where you're going to work on, if you think about those muscles in your pelvic floor as any other, let's just think about them for a moment as if they are just like I don't know, let's say it's your hamstring and your hamstring's tight and it has like a trigger point in it. So we are going to be working on doing some long holds at the muscle to be able to try to get it to release and having you do some breath work. We're going to stretch the muscle by those long, broad holds. And we're not going to be, our purpose is to not make this super painful because when you're dealing with the pelvic floor, it has this attachment to our autonomic system. So if we are causing you to fly up into fight or flight while we're doing this internal work, we're going to not have a outcome that we want because your pelvic floor is going to be flying up right with your nervous system. That's why so much goes into like, if you want the lights turned down, the lights are turned down. If you don't want the lights turned down, we don't have to turn the lights down. Like we want the bed to be comfortable. We want to make sure you're comfortable. There's techniques we can do to try to help bring the system down a bit. Oh, this is where it just starts to get so cool because weighted blankets, different stuff like that can help the nervous system feel safe. And then that helps with the pelvic floor releasing. So it goes beyond just normal, like quote unquote, fascial release or trigger point release in the pelvic floor. And then we start looking at these sort of dynamic treatment approaches that we have kind of developed over time that, I don't know, Roxy, if you want to speak into that. I don't know what else to kind of call it because it becomes more dynamic in the fact that we're not just pressing on a muscle, holding, taking off, pressing on a muscle, hold and taking off.
Yeah, I think that's where that's where the personalization comes in of saying, what does your body need? Like we've done this assessment. We've found some trouble spots. We've found some areas where the muscle isn't functioning like it should be. And so how do we help it to remember how to work well? How do we help it restore health? And that looks different for everybody and everybody's body responds differently. And so there's not a cookie cutter treatment approach. There's not this worked for the last 15 people, so it's going to work for you. Where you're at on, like Megan indicated, like the nervous system, if you're really nervous, there's certain treatments that could be really good for you. But if your nervous system is like, this is awkward and I don't know what I think about this yet, and I'm just unsure and whatnot, that's not going to be good for you. And so we can guess and we can predict and we can know all the things. But if we don't treat you as a person, then we're going to get it all wrong. And we might even do more harm than good if we just put an agenda of fixing the pelvic floor. We have to correct the system. We have to treat the person. And so I think that is where it's really cool to say, okay, we know all these facts. We know all this information about this person's pelvic floor. We also know their history. We know what this pelvic floor has been through in some cases and what experiences this body has been through. And then we choose the best tool we have in our toolbox to treat you where you're at on that day. And that might even look different the next day.
Yeah. And with that too, that's why sometimes pelvic floor therapy can take some time because, progress isn't linear. We are going to be walking through you as you start to improve, and you might have setbacks and you might have twists and turns with that. And then you're going to pick back up again. You're having improvement. Same thing might happen again because the pelvic floor is dynamic. Our body's dynamic. And this is where treating the whole body comes into this. And like Roxy said, you might be in there on one day and you're doing great and you're cruising. And then between those next 2 visits, let's say your daughter got sick for 3 days and it was very stressful and you had to miss work and you didn't sleep and you didn't eat because you were taking care of your daughter and you didn't, like, all this stuff happened. That's most definitely going to, I wouldn't say most definitely because everybody's different, but that impacts our health, that impacts our healing. And so we want to take that into consideration. Maybe when you come back in and see us, you're just like, I am so tired and my back is killing me because I've been taking care of, a sick kiddo. And we can read it all over you that maybe that day, what your body needs is not internal. Maybe your body needs something else that day. And so that's where when Roxy talks about it not being cookie cutter, that's what we're doing. Because we're going to figure out what your body needs. And it's going to, not everybody's going to get better at 2 times a week for 6 weeks. That's just not going to happen. So we can get on that soapbox another day. So yes. So hopefully after going through that and listening to kind of us walking through an internal assessment, maybe it can give somebody that's listening who's been holding back because they're unsure, the extra little push to go ahead and reach out in your area and find somebody if you want to have an assessment done. And obviously, if you're in Kansas, you can reach out to Roxy or I, either one of us or our clinics. And, we can always set up consultation calls or virtual assessments or obviously in person. And also, too, if you're somebody that is, maybe not in Kansas, but you're out of state and you are working with somebody and you are just a little bit unsure, it's always okay to set up virtuals with pelvic floor therapists that you've come across and have a coaching session, walk through, like have somebody look at your history, look at your symptoms, give what they, what would their treatment plan be? What would they look at? That's okay too. I just had somebody call with a similar type of question that lives quite a ways away. And she's just unsure about what's kind of going on. And, we can do that. So hopefully get a little bit more info on internal and doesn't feel so scary now.
Sure. I would just wrap that up with stay curious. If you have questions or concerns, my favorite thing is when people come in and they're like, I know you're going to recommend an internal assessment. I just don't know. Like, be 100% honest. And because that helps us help you better. And so if you have questions, ask them. If you have concerns, voice them. And let yourself be the most informed you can. And know that whatever you need is what you need. And that's okay. And that's what we're here to help you find. And we're here to give you what you need the most of. And so that's my final.
We're going to help give you a little map, a little roadmap, and help guide you. So, all right. Well, we're going to wrap up this episode, and we just thank everybody for listening. If you want to go follow the Pelvis Project on Instagram, we would appreciate that, and give a like or a review and share it. And we will be back next episode and keep the conversation going. Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.